Morning everyone. Today's topic is cardiac output. It is a LAQ asked in the examination as defined cardiac output and the factors affecting the cardiac output. So let us see first cardiac output. Cardiac output is defined as amount of blood ejected by each ventricle per minute. See, per minute, the amount of blood ejected by each ventricle is defined as the cardiac output. It is normally 5 to 6 liters per minute. Cardiac output is the product of stroke volume into heart rate. So, what is the stroke volume now? Stroke volume is defined as the volume of blood ejected by each ventricle with each beat. See, difference between the per minute, it is each beat. Normal value is nearly 70 ml. Then heart rate is defined as the number of beats per minute. It is 60 to 100 beats per minute. So, cardiac output is the product of stroke volume into heart rate, right? Stroke volume is 70 ml, heart rate is 60 to 100. On an average, if I take 70 minutes, then 4900 ml per minute, nearly 5 liters per minute, means cardiac output is in between 5 liters to 6 liters per minute, depend upon the person. Okay, next, this is the defined cardiac output answer. Now, the factors affecting the cardiac output, we will see. See, factors affecting cardiac output. Cardiac output is equals to stroke volume into heart rate. So, the factors affecting stroke volume and heart rate indirectly affect the cardiac output. First of all, you draw a flow chart in the form of first draw a flow chart like this, so that the examiner can understand that you have a great idea about this cardiac output answer, so that you can get a good marks. So, stroke volume is affected by preload, myocardial contractility, afterload, and the heart rate is affected by vagal stimulation and the sympathetic stimulation. Preload is again further affected by venous return, atrial pump activity, ventricular compliance. Venous return depends upon skeletal muscle pump, thoracic pump, abdominal pump, ECF volume, sympathetic activity, right atrial pressure, degree of filling of systemic circulation, resistance to blood flow in venous system. Then atrial pump activity, ventricular compliance. Myocardial contractility depends upon ventricular muscle mass, autonomic activity, hormonal factors and chemical factors. Afterload depends upon peripheral resistance. Peripheral resistance is the depend upon the vessel diameter and the viscosity. Then heart rate depends upon the vagal stimulation and sympathetic stimulation. See, you draw this flowchart in the very first page, such that examiner understand you have a great idea. And next you explain each of them separately, so that you can get a good marks. See, preload. What is preload? Stretching of cardiac muscles fibers at the end of diastole just before contraction. How much the cardiac muscle fibers stretch at the end of diastole, but not after the contraction, but just before the contraction is called the preload. See, due to increase in ventricular pressure caused by filling of blood during diastole, stretching of muscle fiber increases their length. What happened? Due to increase in ventricular pressure, there will be filling of blood in the during diastole, so that there will be increase in their length, causing increases in force of contraction and cardiac output. We have to understand that due to the stretching of muscle fiber, there will be increase in force of contraction. Due to increase in force of contraction, there will be increase in the cardiac output. End diastolic volume is the measure of preload, and end diastolic filling is the preload of the ventricle. See, end diastolic filling only we are defining as a preload. This preload is explained by the Frank Starling's law. It is asked as 3 marks, and it's also asked in the Viva. So once listen, force of contraction is directly proportional to initial length of the muscle fiber within the physiological unit. You should mention within the physiological unit. See, force of contraction is directly proportional to the initial length of the muscle fiber. Initial length means the length just prior to the contraction, just before the contraction, how much the length of the muscle fiber is there, that is the directly proportional to the force of contraction. That is, see, this explains how the increase in length or end diastolic volume increases the cardiac output. See what happened. Initial length. Initial length is the length of the muscle fiber prior to the ventricular contraction. Initial length means the muscle fiber just prior to the ventricular contraction. Depends on the level of stretch of ventricular muscles at the end of the diastole. How much the ventricular muscles can stretch at the end of the diastole. Depends on degree of end diastolic filling. Increase in filling increases the fiber length, increases the force of contraction. See, When there will be increased filling, automatically what happened, the muscle fibers or of this heart will get increase in the length. When there will be increase in length, there will be increase in the force of contraction. Then when there will be increase in force of contraction, there will be increase in the cardiac output. You remember this. Then venous return. Venous return means veins sends impure blood to the heart right atrium, right? The blood from the veins reaching the right atrium is called venous return. Amount of blood that returns to the right atrium from the systemic circulation is called venous return. Venous return is affected by skeletal muscle pump and all other pumps we will discuss. First is the skeletal muscle pump. Skeletal muscle pump. See, if we take this is a heart, these are the lower limbs, right? Lower limbs has veins. These veins sends the blood to the heart. These veins have the walls. These walls open only in one direction. That is only towards the heart, not towards the downward fall. Only blood will move towards the heart. So what happened if this is the lower limb and this muscle? In between muscles there will be the veins. When this muscle get compressed, see this, when muscles move get compressed, what happens, the veins also will get compressed, right? When veins compresses, the blood within the veins moves towards the heart, so that there will be increase in venous return, increase in the cardiac output. That is the uh, skeletal muscle pump. Limb veins contain walls open towards the heart. Only towards the heart it will open. You remember that. Then contraction of skeletal muscle compresses the veins, pushes blood towards the heart. Okay, like this. Then venous return will be increased. When venous return increases, there will be increase in the cardiac output. Next, thoracic pump. Thoracic pump. What happened means, thoracic pump during inspiration, there will be decrease in the intrathoracic pressure. Means it will becomes more negative. When there is decrease in the thoracic pressure, this will transmitted to the great veins. This great veins causes central venous pressure to fall. Decrease in central venous pressure will increases the venous return. That is the thoracic pump activity. See, during inspiration, intrathoracic pressure becomes more negative. How this thoracic pressure will become negative? Due to the expansion of thoracic edge. During inspiration, what we will do? We will expand as much as the thoracic edge so that we can accommodate more amount of the air, right? So during inspiration, intrathoracic pressure becomes more negative due to the expansion of thoracic edge. This is transmitted to the great veins. This great veins to the central venous pressure will fall due to the this decrease in the intrathoracic pressure. Fall in venous pressure facilitates the venous return. Due to the decrease in fall in the venous pressure, this facilitates the venous return. Venous return facilitates the cardiac output. Next, the abdominal pump. During inspiration, what happens? Intra-abdominal pressure rises. Why intra-abdominal pressure rises? What happens during inspiration? Diaphragm becomes descent, like this. It will descend. We will take like this. The diaphragm will become descent. So that what happens? Then intra-abdominal pressure will, like if it is flat, we will have more space. Now see, if it is flat, see it will have this much space. It will become, when descent, then there will decrease in space. So what happened, the air in this will become, the pressure in this will become rises. See, intra-abdominal pressure rises due to the descent in diaphragm. Due to increase in intra-abdominal pressure, compresses the intra. See what happened, due to the increase in pressure, this pressure pushes and these blood vessels get compressed, right? Due to the pressure compresses the intra-abdominal blood vessels, blood is pushed towards the heart and there will be increase in the cardiac output. Next, ECF volume. See, ECF volume greatly influences the venous return because venous return is directly proportional to the ECF volume, especially the plasma volume. See, if ECF volume decreases, there will be decrease in cardiac output. If ECF volume will increases, there will be increase in cardiac output. One of the examples is decrease in ECF volume, as in diarrhea and vomiting we loses water, right? Means as usual we loses ECF volume, so there will be decrease in cardiac output. In increase in ECF increases cardiac output, as seen in pregnancy. This is a physiological increase, not any other increase, but it is a physiological increase. See, when you see the cardiac output of the pregnancy ladies, they will have some great cardiac output. This is the one of the reason to have the great cardiac output. You remember this? They may ask in why. Then sympathetic activity. Sympathetic activity means veins are mostly innervated by the sympathetic fiber. So sympathetic fiber stimulation causes venoconstriction. You remember? See, if this is the heart, these are the lower limbs. You think we have veins in between them, right? When veins get constricted, what happens? The blood in these veins moves upward, right? It won't move downward because walls are towards upward, right? And venoconstriction causes pushing of the blood towards the heart. But venodilation, what happens? There will be no pushing of blood, na? So there will be no increase in the venous return. There will be no increase in the cardiac output. You remember, veins are innervated by sympathetic fibers. Stimulation of sympathetic system causes venoconstriction, increases the venous return. Venous return increases the cardiac output. Based on example exercise, see, the people with the doing exercise have great cardiac output, right? This is the one of the reason. And decreased sympathetic stimulation causes venodilation. There will be no when venodilation, there will be no pushing of blood towards the heart, right? Means decreased venous return, right? So there will be decrease in cardiac output. You remember the reason why the exercise, the people doing exercise have great cardiac output, means this is one of the reason, venoconstriction. Okay, next, right atrial pressure. See, right atrial pressure means the pressure exerted by this right atrium to impede the flow of this blood. The blood coming from the veins to the right atrium, no? That right atrium, right? That flow is impeded by this right atrial pressure. That is called right atrial pressure. It exerts a backward force on the veins to impede the flow of blood from the veins into the right atrium. What we discussed, these are the lower limbs. Is the heart. The blood from this moves to the right atrium. There, the right atrium exerts a pressure such that this blood it impede the flow, means it stop the flow of the blood from these veins to the heart by exerting a pressure called right atrial pressure. Okay, effect is depicted by venous return curve. You draw this curve. See, this is the venous pressure. This is the venous return. Sorry, this is the pressure, right atrial pressure. This is the venous return. Decrease in atrial pressure increases the venous return, right? Because we when if you something is flowing like this, you are obstructing by some pressure, so that it won't move to the respected place, right? Then same, you understand like this only. This is the heart. The blood want to move into the right atrium, but what happened, this right atrium is exerting pressure not to get this blood into the heart, right? So if this pressure is great, means there will be no, even small amount of blood also cannot reach this right atrium. If there will be less pressure, okay, some amount can be moved to the right atrium. So they are inversely proportional. Decrease in atrial pressure increases the venous return. Increased venous return increases the cardiac output. Okay, see, below 2 mmHg, right atrium cannot increases the venous return. See, up to 2 mmHg, there will be no increase in the venous return. It will be plateau. See, it will be plateau. There will be no increase in the venous return. But it become almost zero about 7 mmHg. See, if you take this is a 7 mmHg, the venous return is zero. See, it is not directly proportional. Means with the increase in atrial pressure, there will be decrease in venous return is not directly, means exactly not proportional. Up to some extent only it is proportional. Okay. Then degree of filling of systemic circulation. It forces the systemic blood towards the heart. Means systemic circulation help in pushing the blood towards the heart, so that there will be increase in cardiac output. The resistance to venous return. Resistance means obstructing the flow of this venous return. What happened when we will obstruct the flow for the venous return? There will be decrease in venous return. There will be decrease in the cardiac output. That is only this explanation. Resistance to flow of blood between peripheral vessels and right atrium is called peripheral resistance. Peripheral resistance is the resistance which obstruct the flow of the blood from the peripheral vessels to the right atrium. Important in determining venous return, because the venous resistance increase, blood begins to dammed up in the venous compartment. See, lower limb, heart, veins. Excuse me. See, from what they are saying, venous return, because when venous resistance increases, blood begins to dammed up. See, from this, the blood is from in between these veins, the blood is there. This blood is moving into the right atrium. But due to the resistance, what happened? The blood cannot move into the right atrium. What happened? Then blood will dammed up. Means they will dam up within this venous compartment. When the blood dammed up within the venous compartment, what the blood do? It exerts pressure towards the walls, right? Veins get greater pressure. It increases the pressure so that it want to move to the heart, but there is resistance. To overcome the resistance, it exert a pressure, but the pressure is very less such that it cannot overcome the resistance. See, that is only the explanation. Rise in venous pressure is not effective in overcoming the resistance. So, because veins are highly distensible, we know that veins can distend, means they can accommodate a great amount of blood. They can highly distensible. So, how much the blood accommodate? No problem, because they will distend and they can accommodate what their accommodate the vein blood with extension. But they cannot exert a pressure, but the pressure is very little bit, which cannot overcome the resistance to move into the heart. Rise in venous pressure is not effective in overcoming the resistance because veins are highly distensible. But when we take the arteries are high, not so much distensible. They are tough enough so that they cannot distend. The blood dammed up within this arteries overcome this resistance and move. Okay. See, even slight accumulation of blood in arteries rises pressure greatly because they have less capacitance. Means they cannot accommodate more blood. When some blood only accommodating, they can rise the pressure that can overcome the resistance. So high pressure in arteries over overcome much of the resistance and they can move forward. Resistance to venous return 2 by third by venous resistance and 1/3 will be offered by the arteriolar and small arteries. You just remember that from veins the blood moves to the right atrium. To this, the blood moving to the right atrium, there will be a resistance. This resistance can be overcome only by the arteries because arteries has less capacitance, whereas vein are highly distensible. They can accommodate blood. This accommodated blood exerts a pressure. Okay, they can exert a pressure, but that is not very much such that it can overcome the resistance. So that veins accommodate more blood, whereas this can overcome and it can move forward. Next, atrial pump activity. See, ventricular filling occurs mostly passively. About 15 to 20% filling at rest occurs due to the atrial contraction. See, in cardiac cycle, you will understand. Most of them it will occur by passive. Only 15 to 20% will occur. This is because of the atrial pump activity. You remember. Then ventricular comprehensive. Normally, ventricular muscles is stretchable enough to accommodate adequate blood during the diastole. See, ventricular muscles can accommodate adequate amount of blood during the diastole. Filling decreases in cardiomyopathies due to the increased compliancy. In cardiomyopathies, what happened? The stretchability of these ventricular muscles will be lost. Means there will be increased compliancy. Due to the increased compliancy, what happened? They will accommodate less amount of blood. When there will be less amount of blood, there will be less contraction. There will be decreased in cardiac output. We see these aged people have less cardiac output because of this. One of the reason. Okay. Next, myocardial contractility. We saw preload. Now myocardial contractility. Then afterload. Myocardial contractility. See, major influence of cardiac output by this myocardial contractility only. Factors that increases myocardial contractility are called positively inotropic, and factors that decreases myocardial contractility are called negatively inotropic. Myocardial contractility is affected by four factors. One is the ventricular muscle mass. See, ventricular muscle mass decreases due to loss of myocardium as occurs in myocardial infarction. Then there will be decrease in cardiac output. See, ventricular muscle mass is directly proportional to myocardial contractility. You remember. Ventricular muscle mass will decreases in cardiomyopathies and myocardial infarction in aged people due to the every time the heart works na. So what happened as age advance, some of the myocardial muscle mass lost its activity. What happened then? There will be decreased cardiac output due to the decrease in myocardial contractility. That is only remember enough. Ventricular muscle mass decreases due to loss of myocardium as occurs in myocardial infarction. Then there will be decrease in cardiac output. That ventricular muscle mass is directly proportional to myocardial contractility. In ventricular muscle mass increases, cardiac output increases as in regular practice of physical exercise. See, the persons who perform physical exercise have great cardiac output. The reason behind this is the increased myocardial contractility. Whereas the person with ages has great age will have the decreased cardiac output due to the decrease in ventricular muscle mass. Whereas the physical exercise person will have the greater muscle mass, so that greater myocardial contractility, so that the greater cardiac output. Next, autonomic activity. Sympathetic stimulation increases ventricular contractility, so that it increases the cardiac output. Next, hormonal factors. See, the substances which increases cardiac output are positively inotropic, right? Catecholamines are positively inotropic. How they increases this myocardial contractility? We see. Catecholamines act on beta 1 adrenergic receptors in the ventricles. Ventricle has these receptors. They act on these receptors. These receptors, what they do? They increases the adenylate cyclase activity. This cyclase activity increases the cyclic AMP in muscle cells. Cyclic AMP increases intracellular calcium, so that myocardial contractility increases. See, we know that calcium is important for the contraction, right? So that in that way, it will increases the myocardial contractility. Next, acetylcholine. They have muscarinic receptors. Muscarinic receptor causes decrease in cyclic AMP, so that they decreases the myocardial. See, remember, acetylcholine is negatively inotropic, right? You are saying, right? They what they are doing, they decrease the cyclic AMP. When cyclic AMP decreases, there will decrease in intracellular calcium. Decrease in intracellular calcium decreases the myocardial contractility. Next, glucagon. Glucagon increases cyclic AMP. There will be increase in myocardial contractility. Insulin also one of the positively inotropic only. You remember. See, thyroxine. Thyroxine increases the myocardial contractility in three ways. One of the ways, they increases the beta 1 receptors in the nodal tissue and ventricular mass. Heart has nodal tissue, right? And ventricular mass we discussed, right? In that we will have receptors. This thyroxine, what it do? It causes beta 1 receptors to increases. When beta 1 receptors increases, CAMP increases. CAMP, calcium, and further myocardial contractility will be increases. In another way, how it will increases means increases the sensitivity of these receptors to catecholamines. It makes these receptors to become sensitive to the catecholamines. Means some amount of catecholamines you give, they show greater response because it increasing the sensitivity. Okay, then it causes tachycardia and increases the myocardial contractility. In another way, by increasing the myosin ATPase activate in ventricular mass, it increases the myocardial contractility. Myocardial contractility increases the cardiac output. Next, chemical factors. Chemical factors means digitalis is one of the chemical used to increases the myocardial contractility. How it increases myocardial contractility means it inhibits the sodium potassium ATPase pumps in the heart muscle, so that myocardial contractility will be increased. Xanthines such as caffeines and theophylline increases the myocardial contractility by inhibiting the intracellular breakdown of CAMP. If CAMP is not breakdown, then there will be increase in calcium, right? When calcium increases, there will be increase in myocardial contractility. It inhibits the breakdown of CAMP, means it promotes the formation of cyclic AMP, right? Next, afterload. Afterload is the force against which ventricular muscle fiber shorten. Essentially, the resistance offered against ejection of blood from the this is the resistance. Afterload is the resistance offered against the blood ejecting from this ventricle. It is nothing but peripheral resistance is considered as the afterload. Afterload is also called as peripheral resistance. Remember that peripheral resistance is indirectly proportional to cardiac output, because it is what it is doing, it is resisting the ejection of blood from the ventricle, so that there will be decrease in cardiac output when peripheral resistance is increases. Okay, peripheral resistance depends upon vessel diameter and viscosity of blood. Vessel diameter, see, aortic arch, pulmonary artery. This, when there will be increases in vessel diameter, what happens? There will be increase in blood coming to the heart, so that there will be increase in the cardiac output. If vessel diameter decreases, then there will be decrease in stroke volume and there will be decrease in the cardiac output. Just remember, vessel diameter, decrease in vessel diameter decreases the increases the peripheral resistance, so that there will be decrease in stroke volume. When decrease in stroke volume, there will be decrease in cardiac output. Stroke volume increases in vasodilation. Okay, vasodilation increases cardiac output. Vasoconstriction, what happened? Causes decrease in cardiac output. Viscosity of blood. Viscosity of blood increases the peripheral resistance. Peripheral resistance if increases, then there will be decrease in the cardiac output. Blood viscosity increases, peripheral resistance increases, cardiac output increases. It is seen in polycythemia. It is a disease condition in which there will be viscosity of blood will be increased, so that peripheral resistance increases and there will be decreases in cardiac output. Cardiac output increases in anemia due to decrease in viscosity. See, anemia person will have one of the symptom that they have greater cardiac output. This is one of the reason due to the decrease in the viscosity. Due to the decrease in viscosity, what happens? There will be decrease in peripheral resistance. When peripheral resistance decreases, then cardiac output will be increased. Okay. Next, heart rate. Heart rate is influenced by autonomic activity, especially vagal stimulation and sympathetic stimulation. Vagal stimulation decreases heart rate and sympathetic stimulation increases heart rate. Unless associated with increased venous return, heart rate may not increase the cardiac output. You remember, see, when venous return associated with increased heart rate may not increases the cardiac output, means unless venous return is not associated excuse me, may not increases the cardiac output. In tachycardia, how tachycardia means increased heart rate, right? In tachycardia, what happened? How the heart rate is increasing means duration of diastole shortens, then the systole will be normal, but the diastole will be shortens. So ventricle gets less time to get filled. Thus, end diastolic volume decreases. When ventricles get less amount of blood, then there will be decrease in end diastolic volume. So that cardiac output does not increase proportionately to that of heart rate. See how much means, you remember, heart rate will increases greatly, but when heart rate increases greatly, there will be not much increase in the cardiac output. He want to say that is, see, cardiac output does not increase proportionately to that of heart rate. If heart rate increasing 10 times, there will be increase in one time of this cardiac output. That much one. There will be no great increase in the cardiac output. This is the flow chart you can understand. When diastole shortens, there what happened? The ventricles get less time to take filled with blood. Means end diastolic volume is decreasing. End diastolic volume decreases, cardiac output to increase, but not as much as the heart rate increased. Similarly, when heart rate decreases, diastolic filling of ventricle increases. This is compensated to maintain the cardiac output. That is the heart rate. See what we discussed: cardiac output is equals to stroke volume into heart rate, right? Stroke volume and its factors: preload, myocardial contractile, afterload. Heart rate is determined by vagal stimulation and sympathetic stimulation. So this is the cardiac output factors affecting the cardiac output, and defining definition of cardiac output. This is the LAQ asked in the examination. You have to explain by using flowchart such that you can get a good mark.